get started. I'm Scott Allen. I'm the CEO for the Family Medicine Education Consortium, and welcome tonight to our first learning session in our quality improvement project around hereditary breast cancer. So we're super excited that you've joined us. We have 8 clinics and residency programs joining us on this project, and we're thrilled about that. Glad you could all make time, and I think you're going to be very happy with what you learn and what you're able to improve in your clinics. So with that, I will get into the presentation. First, I just want to make sure to acknowledge our sponsors. The Family Medicine Education Consortium is receiving a subcontract from the National Association of Chronic Disease Directors, and that their funding comes from the CDC. And the CDC and the National Association of Chronic Disease Directors have created this project to help families communicate about hereditary breast and ovarian cancer. So we're very grateful to be included, and I want to thank them for recognizing the important role that family physicians can provide in risk factor identification and screening and helping patients through this journey. So as you know from the communications you've received from our project, this is one of 3 required trainings for family physicians and for your residents who are participating in order to claim the performance improvement credit. This is tonight, and then we will have one more on January 25th on quality improvement basics, and one after that on February 1st about the project itself, the structure, the timeline, things you'll be doing in your clinics. And just to reiterate, this project is approved for up to 20 performance improvement AAFP prescribed credits. We will be providing you with a certificate once you've completed all the required trainings, and there'll be more information on this coming to you later. I just want to start by thanking our project advisory committee. We've had this project for about 1.5 years now. We did a phase before this phase where we worked with about 9 residency programs just to learn more about the tools and resources that the CDC has developed. But through along, we've had a great project advisory committee, some of whom you'll meet tonight. Susanna Evans from Temple, Tracy Conti from UPMC, Philip Day from UMass, and Adam Perrin from University of Connecticut School of Medicine, who unfortunately had to drop out, but he's been all along the way with us on this project. And with that, I'm going to turn it over to Dr. Conti to get us started.
Hi, everybody. Again, thank you for joining us. I am Tracy Conti. I'm the chair of family medicine at the University of Pittsburgh and UPMC. I'm excited to present today's speakers. We have Dr. Susanna Evans, and I'll introduce her in a little bit. And we were set to have Anya Karnakov. Unfortunately, Anya was unable to join us today because of illness, and Scott Allen, who you just heard from, will present those slides. I will introduce both of those speakers in a little bit. And so I do want to note that none of our speakers today have any disclosures, and none of the project advisory committees or anyone involved in the development of the content have any financial or commercial interest to disclose. Again, we are excited to have you guys join us today. We do have 8 family medicine residency programs that are participating in this phase. You all have received these slides. We do want to call your attention because your assigned QI coach and email to that QI coach is listed with this slide. And you have this contact and the information that was sent out. And so please feel free to reach out as you go through this journey. We also just wanted to highlight, some information, some demographic information about the programs that are participating. The programs range from a group of size of residency of 12 up to 44. There are participants in this group that were with us in phase 1 and some that are brand new. As we continue to go through this project and get more demographic information, we'll be sure to spread that and give that information to you. And again, we're excited to have a variety of people participating and ranging from urban to inner city to rural, and feel like this is a good collaboration between all of us. And so here are some, sorry, I went too fast. If I can go back. My apologies, everyone. Rebecca, are you able to take control and get us back? It's not allowing me to go back.
There you go.
Very good, thank you. So these are our learning objectives for today and for this educational group. Understanding the risk and incidence of breast and ovarian cancers. We're going to talk about the breast cancer screening tools and how to incorporate them into practice with patients. Really learn about the benefits of utilizing stories during our patient visits, and how do we incorporate the CDC Bring Your Brave and patient education materials as a tool for our visits. We really want the participants to be comfortable in how they discuss is raising awareness about cancer risk during those annual visits. It's important, especially in family medicine, for us to understand the role of genetic counseling, testing, and referral, and increase our knowledge so we're able to get that information to our patients. And lastly, how do we utilize narrative medicine as a tool for opening that communication with patients? And so next slide. I know, great. With that, I will turn it over to our next speaker. Dr. Susanna Evans earned a BA from Elizabethtown College with a degree in English. She earned her doctorate in medicine at Penn State University College of Medicine. And then she completed her family medicine residency training at the Shasta Cascade Family Medicine Residency Program in Redding, California, where she also served as a chief resident. Dr. Evans, after residency, completed a rural family medicine obstetrics fellowship with Tacoma Family Medicine. She currently serves as the associate professor and chair of family, community, and preventive medicine, Drexel University College of Medicine, and faculty with Temple Northwest Community Family Medicine Residency Program. Her academic interests have always included family medicine education, women's health, preventive medicine, end-of-life care, quality improvement, and leadership. And I will turn it over to Dr. Evans.
Hi, thank you very much, Tracy. It's great to be with you all tonight. I wanted to start out by just telling you a little bit about why I became interested in this project. So I'm a breast cancer survivor myself. My grandmother in her, I think, 70s, maybe late 60s, was diagnosed with breast cancer. My mother had breast cancer in one breast when she was 70 and the other when she was 80. Neither which, based on the age, would have conveyed a whole lot of risk for me in particular. But then my sister was diagnosed with breast cancer in her 40s. At which point my mom and my sister had genetic testing done, and they were BRCA negative, and they both had the same variant that at that time was of unknown significance. So I got hooked up with a breast surgeon, and what she said to me was, she felt I was high risk, and we didn't need the genetic testing to know that. And so I began, I would say probably around age 48, doing every 6 months, alternating a mammogram and an MRI. And at age 53, I got diagnosed with breast cancer. It's was probably like the best case scenario if you're going to get breast cancer, because of the high surveillance. It was found really early, and while it was invasive, there was no spread to my lymph nodes, and so I got a great diagnosis and a really good prognosis. And a lot of that was because somebody took the time to identify me as high risk and treat me differently than the average patient, for which I'm grateful. And so I'm really hoping that we can bring this to family medicine and help to identify people who are at high risk. All right, I can't seem to take control. I don't know if somebody else can advance the slides, because I can't.
Were you able to wiggle your mouse?
Yeah.
Okay. Okay, Rebecca will help us out. Hang on.
Well, we moved ahead at least one slide here. So why is it important for us to identify people who are at risk for early onset breast cancer? 9% of breast cancers occur in women who are 45 and younger. Women in this age group are more likely to have a hereditary breast cancer. And because breast cancer in this age group is found at a later stage, it's often more aggressive and difficult to treat. Unfortunately, many young women do not know the risk for breast cancer or ways to manage the risk. As family physicians, we need to identify women at higher risk of breast cancer and refer them for appropriate testing and screening. A lot of times we're the only doctor that a woman at that age is seeing. And so we really need to take advantage of that opportunity with the patient. According to the CDC, only 41% of primary care physicians refer a woman with high risk for breast cancer for genetic counseling or testing. And this is another study that basically shows that only 1 in 5 high-risk patients were being referred to, which is concerning. What are some of the risk factors for early onset breast cancer? According to the American Cancer Society, women who are at high risk are women who have a known BRCA1 or BRCA2 gene mutation. What I think is really important for this group and for family medicine to know is this next one that's in bold. Anyone that has a first-degree relative, which is a parent, a sibling, or a child, a second-degree relative, which is an aunt, uncle, niece, or grandparent, or a third-degree relative with a cousin with a BRCA or BRCA2 gene mutation. So if it's anywhere out there in the family tree, it's really important for us to know about that. If women who have a lifetime risk of breast cancer of 25% or greater, according to risk assessment tools, and we'll talk about them in a minute. Any woman who's had radiation therapy to the chest between the ages of 10 and 30 years, and then anyone has one of these syndromes or a first-degree relative with one of these syndromes. So these are some tools that we've put together to assist you in assessing your patient's risk for breast cancer. After this presentation, Rebecca's gonna send this out to everybody in the form of a PDF, and you'll be able to activate these links. It's gonna be very important, you know, in the next few days, really, to decide what tool your group will be using if you aren't already using a tool. Next slide, please. So this is a highlight of some of the main tools. You'll see referenced a lot the Cusick-Tyer model, and that's used in research. It's also supposed to be the most consistently accurate for predicting breast cancer, but I find it a little bit cumbersome to use. My preference and the one we use in our group is the Gale model. In our previous version of Epic, it was actually embedded, so it was really easy to use. Unfortunately, it's not anymore, but you can find the Gale model also in MD Calc if any of you use that, or you can just Google Gale model and it pops up. It's, I want to say, maybe like 5 questions, so it's pretty quick to get through in a visit. And then on the Bring Your Brave website, there are other genetic risk assessment tools and breast cancer risk assessment tools. So what are the recommendations for genetic counseling and testing? The American Cancer Society recommends genetic testing for women at high risk to look for mutations in the BRCA1 and BRCA2 genes. They're careful to say that while testing can be helpful, we really need to weigh the pros and cons with the patient before advising testing. And the American Cancer Society strongly recommends that women first talk to genetic counselor, nurse, or doctor who is qualified to explain and interpret the results of these tests. The United States Preventive Service Task Force recommends that women who have 1 or more family members with a known potential harmful mutation of the BRCA1 or BRCA2 genes should be offered genetic counseling and testing. Women with an identified risk factor should be referred to a genetic counselor who can further evaluate the risk based on family history, discuss the pros and cons of testing, and arrange for BRCA testing if the patient is ready to proceed. The National Comprehensive Cancer Network has screening guidelines that recommend that you screen women with BRCA1 or BRCA2 mutations or with a first-degree relative with these mutations. High-risk women should get mammogram and breast MRI yearly, starting at age 25 to 40, clinical breast exams every 6 to 12 months, beginning at age 25. The American Cancer Society has the same recommendations for yearly mammogram and breast MRI, but they recommend beginning screening at age 30 or age recommended by the healthcare provider and continue for as long as they are in good health. I'm going to pass it back to Tracy.
Yeah, so Susanna, thank you so much for that presentation. We are going to turn this over again. Anya was unable to be with us tonight. And so Scott Allen, I'll introduce him next. And so while you heard from him earlier, I just want to tell you a little bit more about Scott. He serves as the CEO for the Family Medicine Education Conference, the Family Medicine Education Consortium, and he's been in that role since November of 2021. He has over 30 years of experience managing nonprofits, including 24 years in healthcare, working with primary care providers at the state and national levels. He is so enthusiastic about supporting the FMEC to undertake quality improvement projects that meet ACGME learning collaborative and performance improvement requirements. So Scott, I will turn it over to you.
Thank you so much, Tracy. And I really appreciate being here. And I'm so sad for Anya Karavanov, who is our contact with the National Association of Chronic Disease Directors. She's so passionate about this work and has done so much work to get the Bring Your Brave campaign, which I will describe to this stage. So I hope you'll all meet her at a future learning session. And we definitely at the FMEC thank the NACDD and the CDC for all their great work. The CDC launched the Bring Your Brave campaign in 2015 to provide information about breast cancer to women younger than age 45. The campaign tells real stories about young women whose lives have been affected by breast cancer. Through these stories about prevention, about risk, about family history, and survivorship, Bring Your Brave aims to inspire young women to learn their risk for breast cancer, talk with their healthcare providers, and talk with their families, and live a breast healthy lifestyle. The campaign also has elements that educate healthcare providers on the risk factors for breast cancer before the age of 45, which helps them understand the barriers that patients may be facing. So why is the campaign important? I don't want to reiterate what Dr. Evans has shared, but just to emphasize some of that, research shows that BRCA-related cancer risk can be reduced by 90% or more through preventive options. Yet only about 10% of those with BRCA mutations in the US are aware they carry the mutation. Few discuss testing with their healthcare providers, and that's particularly true for Black and Hispanic women. Primary care has been repeatedly identified as the most opportune setting to conduct breast cancer risk assessment. Yet less than a quarter of women at high risk for breast cancer were referred to a BRCA1 or 2 testing in accordance with the US PSTF guidelines. And 3/4 of primary care physicians never referred a single patient for genetic testing. Conversations with healthcare providers about family cancer risks are critical to identifying women at high risk, but only few patients have these conversations. Recently, the CDC conducted a study of about 22 focus groups with women ages 18 to 44. Among other things, the study addressed motivators and barriers to accessing genetic counseling and cancer screening. So according to the study, women most often reported factors like perceived costs, lack of health insurance, lack of access, fear, lack of trust, lack of information, as well as being written off by providers as being too young to be concerned about breast cancer. Those were the barriers they cited to talking to their healthcare providers and pursuing genetic counseling and testing options. On the other hand, women were more likely to have family conversations when they have knowledge of how to discuss family history, what to ask, they have supportive family members, and they feel comfortable discussing the topic when they're prompted by their healthcare provider. So one of the main strategies of the campaign is to feature real women and some men, as well as healthcare providers, to tell their stories to bring this issue to life. Patients we feature deal with prevention, risk, family history, and survivorship. As you know, as healthcare providers, stories can make issues more real and identifiable. Plus, stories are more engaging than traditional educational communication materials because they tap into our emotions. So these stories work for both patients and for healthcare providers. For patients, the stories can drive home the reality that young women can be personally affected by breast and ovarian cancer. They also help them feel less alone in their struggle. And when they see someone who looks like themselves or someone they know, they may be more likely to make a connection between what that person is sharing and what their own life experience is and what they should know. Patients in these stories also do model the desired behavior. So they seek genetic counseling, they talk to providers, they talk to their family. For healthcare providers, these stories and watching patients talk about their personal experience can help them better understand the issues that your patients are facing. Learning about how patients deal with certain diagnoses, or about the many non-clinical factors that impact the way they cope with treatment and recovery, that can help improve the way providers approach patient care. So this storytelling approach is aligned with narrative medicine. And we won't be going into a lot of detail about narrative medicine in this session tonight. We did with our first cohort of this project, do a little bit more dive into narrative medicine. And we have some recorded webinars from that. And we also are developing as a separate part of our project at FMEC, CME module around narrative medicine and hereditary breast cancer. So narrative medicine is an interdisciplinary field that combines the art of storytelling with healthcare. It focuses on understanding patients' experiences, emotions, and perspectives through personal narratives. In family medicine, narrative medicine has emerged as a powerful tool for enhancing patient care. By harnessing the power of storytelling, healthcare providers can delve deeper into patients' experiences, understanding them on a more profound level. This approach not only fosters empathetic connections, but also helps in delivering personalized and holistic healthcare recommendations. So even though providers are taught to have good communication skills, as you all were or are in your residency program, patients frequently complain that doctors don't listen, or they appear disinterested, or they make assumptions or recommendations that don't really address the patient's own concerns. And on the other side, doctors sometimes say that patients can be difficult, or that they have time pressures and they can't communicate everything they want to, or that there's other factors that are hampering effective communication. Narrative medicine seeks to increase empathy and understanding and make these communications stronger. Specifically, narrative medicine can help patients and providers find common ground around a couple different things. So around mortality. Doctors learn to understand illness through their training, and they see it every day, but a patient often experiences illness as unexpected, and they bring their past experiences as well as their fear of the future of further illness or death. In the context of illness, doctors quite naturally view illness as a biological phenomenon that requires a medical intervention. Patients view their illness within the framework of their entire lives, everything that's going on with them. In terms of beliefs about disease causality, patients don't have the medical knowledge of doctors, and so their notions of illness and its causes can vary widely. But when the ideas of causality are conflicting, the care can be compromised. And then shame, blame, and fear. Patients may be embarrassed revealing intimate details of their lives and aspects of themselves, and the illness can make them feel fearful and vulnerable. They might be searching for blame, blaming themselves or even their providers. And doctors equally can have difficult times asking very personal questions, and they can also bring blame into the conversation in terms of the patient's behaviors or other factors. And these emotions on both sides affect the illness experience considerably. So having things like narrative medicine, these videos to help understand the other perspective is very helpful. Narrative medicine shifts the doctor's focus from the need to problem solve to the need to understand. And as a result, the patient-doctor relationship is strengthened and the patient's needs and concerns are addressed more effectively. So to help patients and doctors navigate these difficult conversations and help providers build empathy, the National Association of Chronic Disease Directors and the CDC have developed these resources under the Bring Your Brave campaign. These are really critical resources that we're going to ask you all to spend some time after this session looking at, make sure all your care team members are familiar with them, explore. I think you'll find it really engaging and fun, but there is a lot there. So there's a conversation simulator. It offers guidance on how to navigate difficult conversations about hereditary cancer. There's 2 video series of breast cancer survivors and previvors sharing their experiences. There's a video series featuring young women who are the first in their families to learn about the risk of hereditary breast and ovarian cancer, and that those videos give advice on how to make family conversations easier and how to start those conversations. And then there's additional supporting materials like fact sheets and conversation guides and provider education, some of which we'll mention in a minute. But the best way really to help you understand what's on the Bring Your Brave website is to show you one of the videos, two if we have time. So I'm going to let this video play. This is a story of a father and a daughter, Arnaldo and Vanessa.
That's my great daughter.
And this is my father, my amazing dad. And he's a wonderful support system.
So I remember I was showering, I felt the lump on my right side. So I went to my primary doctor. And she examined me and she says, you know what? Let's get it biopsied. About a week later, they called me. They said, all right, you have male breast cancer. Then I said, y'all playing with me. Men don't have, they don't get breast cancer. And they said, oh, you got to get genetically tested. And through that, I found out that I carry the BRCA2 gene. I said, wait a minute, I could give this to my kids.
He called and was trying to explain it. And at that time, I think I was like, I'm 32, I'm young, no problem. But then my doctor, she's like, just to be proactive, let's get a mammogram. And that's when they found my cancer.
So right there, I hit rock bottom. I took it as, wow, I passed this on to my kids already? But she said, Dad, we're gonna beat this. Don't worry about it, we're gonna beat this.
He would go to my chemo treatments, I would go to his. Yeah.
And that's how we got through. We got through.
You always hear a father and daughter bond of dancing or fishing or basketball. But our bond and what got us close together was breast cancer. I think he saved my life. Because if he did not find this, by the time I would have hit 40, it would have been too late.
She was my rock. And she's my daughter and I love dearly. But she's my friend.
So that's one video of many that are very powerful and affecting. And as we mentioned earlier, I think people can find ones where they see themselves, they see people they know, and hopefully it will help patients talk about the issue, bring things up. I really encourage you to go watch more. And
that's my great daughter.
If I can get it to advance to the next slide, we will watch one more. There we go. So this is a video, a story from a healthcare provider's perspective that was developed through a storytelling workshop. So let's watch this and then we'll move.
Every single appointment with you and sat beside your.
I think it started, I'll start at the beginning.
It was a Tuesday in early fall, about 2 months after you finished your chemotherapy, when you came to see me in clinic for a follow-up appointment. You came to clinic with your mom. She came to every single appointment with you and sat beside your bed on alert when I met you in the hospital for the first time several months earlier. Your trip to the emergency department that day for unexplained abdominal pain uncovered something far more serious than anyone would have ever imagined. You showed up with abdominal pain and left with a cancer diagnosis. Ovarian cancer specifically, spreading quickly and aggressively despite your young age and previously perfect health. On that particular day in clinic, I remember the enthusiasm as I walked in the room. You wore teal and proudly brandished your phone. I was intrigued as you quickly located a photo you wanted to share. You stood by the ocean, the wind in your hair and the sand between your toes. Your extended family surrounded you on either side like a huge hug, and each of you smiled so hard it radiated through the screen. Your mom, your best friend, stood closest to you. She was the only one whose eyes weren't on the camera. She was too busy looking at you, beaming with pride and with a special understanding of all you had been through in the months that had preceded that moment. Your mom bore witness to a lot during the course of your diagnosis and your treatment, not the least of which was the complex range of emotions around conversations and testing to determine whether this disease would also affect her other children. I marveled at both of your strength and vulnerability through it all. On that particular day in clinic, my eyes stung and I did everything I could to fight back happy tears. I try hard not to make my work as a physician about me, but I care, and I always will. After one particularly difficult treatment about halfway through, one that momentarily seemed to puncture your normally ironclad resolve since we both knew that your prognosis had changed, you told me about your plan. A plan that served as our mutual motivation to reframe and widen our definition of treatment success, and one that reminded me that life is as much about the little things as it is about the big ones. All I want to do is stand by the ocean and see forever out in front of me. And stand by the ocean in the purest of joy you did.
So again, very powerful, and it makes you stop and think about what you're doing in your day-to-day practice. And there's so many more videos on the website. I really encourage you to go to the site, maybe bring all your care team members in and make a challenge of it. Ask everybody to review a couple and then share. It is hard to get familiar with everything that's on the site, but the more you can be familiar with it, the easier it will be to recommend things to patients and to use them in your training as well. So there's more to explore, but we know it'll be worth your time. And how do we know this? We know this because we have done an earlier cohort where we really just helped expose 9 family medicine residency programs to these resources and asked them to consider using them both in training and in practice. And all of the programs, nearly 100% of the participants in the project, reported that they thought the materials would have a positive impact on patient outcomes through one of any of these ways. It increases provider knowledge and increases their comfort about the topic. Earlier in that cohort, we asked how comfortable you are talking about hereditary cancer or about genetic testing, and people were not that comfortable, but by the end of the project, they thought they would be more comfortable. It increases empathy by providing insight into the patient experience, and it also increases motivation for physicians and other healthcare providers to do better, to learn from other physicians' experiences and use the simulator to figure out how to hold those difficult conversations. So lots of great resources. And there are also some just general straight educational resources for healthcare providers that we encourage you to look at about assessing risk and strategies for managing risk. There's also some continuing education courses which were developed by the American College of Obstetricians and Gynecologists. So some really good information there. And with that, I am going to apologize again that Anya Karovanov couldn't be here to give you that talk, but hopefully I was able to get you excited about Bring Your Brave. And I'm going to pass it back over to Dr. Evans.
All right. See if I can get control this time or not. So we just want to reemphasize the importance of genetic testing. I think we've been talking about this throughout this presentation. But what came out of our learning collaborative previously was that only 25% of the participants surveyed felt comfortable discussing genetic testing options with patients. Only 13% of the participants surveyed felt comfortable discussing genetic testing results. And 100% of the participants surveyed agreed that improving provider education around genetic testing would increase comfort levels and subsequent frequency of hereditary cancer discussion with patients. These are some resources that you will have access to again after this presentation. You'll be sent a PDF and you'll be able to click on each of these to go through and look at the resources and see what might be helpful to you as you put your resource toolbox together. What you're going to want to do is begin to gather information and tools to facilitate your conversations with your patients. And the best way to do it is to be prepared. We recommend putting together a folder of resources, either online or paper, whatever works for you in your setting. For the healthcare providers, there's fact sheets that you can pull off of Bring Your Brave. Other educational materials. You can compile a referral resource list for your providers. So who are you going to send them to for genetic counseling if you decide that needs to be done? Who are the breast surgeons in your area? What resources do you want to have to take this further if needed? And for patients, you're going to identify local support resources that are available to the patients, community groups, social service agencies, or potentially even church programs, and identify options for providing patients access to the Bring Your Brave campaign. What you see pictured here is a flyer that we put together with a QR code. So you could hang that up in a patient room while the patient's waiting for you to come in. They can, take a photo through the QR code and it'll take them to the Bring Your Brave website. And then there's so many options. I believe a lot of these options were what came out of our last group, but options for helping your community access the Bring Your Brave resources. The QR code, as I mentioned, we've talked about maybe providing iPads in the waiting rooms, playing the videos on TV screens in the waiting rooms, some other ones, making sure we incorporate these discussions into new patient and annual wellness visits and well woman exams, and schedule follow-up appointments when we just determine a woman is at high risk. Now we're just gonna take the opportunity to open the floor up for questions.
Well, before we get to questions, I just wanted to take the opportunity to say thank you to both Scott and Susanna for presenting. And again, thank you all for coming. Please feel free to come off of mute and ask questions, or if you prefer to put them in the chat, we'll be monitoring both. But we'd really like to hear your questions or even comments that you have tonight.
Question for the folks who are in like the first cohort. This is Tom McGinley from St. Luke's. And since we weren't part of that first cohort, what were like strategies used? Our base team of 5 is actually all in this meeting right now, but we want to engage all of our practitioners, all of our faculty and residents. So what were some ways that people utilized to engage the groups previously, or what are some of the ideas that the current groups are thinking about to engage the entire practice, not just the team that's going to lead our charge?
So I can pop in with an example and then Scott, I'll turn it over to you. I know that some groups, they would send somebody to the live session and then that person would then present that either as a didactic or be there to answer questions. And they incorporate it into the learning session. So that's one way they distributed information. And Scott, feel free if there's other things that you know.
Sure. So I know a couple of the practices, as Dr. Conti mentioned, did kind of in-services for themselves and had certain people watch things and share the information. We also do have from that first cohort a kind of Excel spreadsheet with all the videos. It's kind of hard to know how much there is, so we actually compiled that. And then some clinics use that to say, well, I'll watch these 5, I'll watch those 5, and then share. So we can make sure to send that out. Rebecca Book, who's been managing this webinar, and Kathy Fredericks, who I neglected to mention earlier, are our 2 staff consultants on this project. So they're doing a great job, and they can help get you some tools and anything we did from the first cohort that'll be helpful, we will make sure to share.
Thank you. That spreadsheet might be helpful. And we could probably incorporate this into our didactics too, now that you mentioned that. Right now we're finishing up a grant where we're teaching eating disorder screening to our residents through a grant and didactics, but I think this might lend itself to that as well. So thank you for the idea. Another question, I'm sorry, I don't want to monopolize, but I do have one more question. And I think I asked this when this was proposed at an Fmec workshop, but and Sue may have even touched on this with me before, but I'm senior moment here. Are all the institutions going through like either IRB or IRB exemption for their participation in this?
You want to take that one, Kathy?
Hi, Dr. McGinley. This is Kathy. I sent a message out to the QI leaders, letting everyone know that while we were hopeful that we were going to be able to apply for global IRB as exempt and expedited, given the large nature of the project and the fact that we have 8 programs in different localities, it just wasn't going to be feasible. And so I brought that back to the project advisory committee. And while we think it would be helpful to pursue local IRB, because we're not planning to publish in a journal on this pilot project, it's not absolutely essential. But I think it does behoove all of the QI leaders to pursue asking your IRB if you would be eligible to get approval as a QI project that would be exempt. We don't want to be in a position where we're going to have to ask patients for permission to talk to them about breast cancer or hereditary breast cancer. And we're really not tracking outcomes of the patients. This is more process improvement. What we want to try to do is help you all set up processes, develop a policy around risk assessment for hereditary breast cancer, and then test it out and implement it in practice. So if you're able to pursue local IRB and get that, then when you towards the end of the project, look into perhaps having your residents do a poster at a future conference, because we are providing stipends for that. You'll already have a determination that says basically your QI project was exempt. But if you don't get that, you still will be able to submit for posters through the FMEC and the Society for Teachers of Family Medicine to do a poster, because they don't have a requirement that you have obtained IRB. And since I don't envision anybody in the pilot stage wanting to publish on their QI project, it won't be essential to have it. However, if anybody does want to pursue publication, which you're more than welcome to do so, then you definitely should be pursuing local IRB. So I hope that helps. And if anybody else on
that's very helpful, actually. And On the call is Dr. Alincia Mashad, our postdoc research fellow. So our group will talk with our own institution about getting our own either expedited exemption, or if it makes sense, if we want to publish internally, like, what we find, go through the IRB process. So, but that helps me, and I appreciate it. Thank you.
Okay.
I just want to note that there was another question in the chat around the resources being in languages other than English. And I know there was a conversation, Scott, if you just want to expand on that a little bit.
Yeah, and Rebecca can correct me if I'm wrong, but we did bring that up early in the first cohort, and one of the practices in particular, which had a majority Spanish speaking population, was kind of struggling a little bit on how to use these resources. And unfortunately, they did not invest in creating other language versions of these videos. We've asked if we can translate handouts and other things. They're a little bit hesitant to let us do that, but I think you should do what works for your practice. If you need something in a different language and you have staff or a resource that can help turn it into that language, go ahead. It's the best way to communicate to your patients. But in the meantime, we're asked if more of these resources can be in Spanish, citing the need, Spanish specifically, citing the need, and hoping that they'll make some progress on that.
And just to add to that, Rebecca and I were looking on the CDC website, and as it turns out, the CDC does not have the Bring Your Brave materials available for in Spanish translation, for example, right now. However, on the CDC website, there's different areas you can look, and we will help you get this information. But you can go to the CDC website and you can search for resources in Spanish language on mammograms and on like dense breast and like what that means. So there is quite a bit in Spanish on the CDC website. It's not within the Bring Your Brave campaign, it's outside of it. And Rebecca and I are working together on a resource that we can push out to the QI leaders, and you can push it out to your teams and your participants, so you can access some really good information that is already available in Spanish. I don't know if it's available in other languages beyond Spanish, but at least that is a good place to start. And we can make the plea back to Anya that poster that Susanna referenced that has the QR code, if we could at least get that poster in Spanish, it would take them to the Bring Your Brave website. But again, if it's not in Spanish and they're primarily Spanish speaking, that's probably not going to help them so much. But we will be pushing that out to you all. Whatever information that we know that is already available in Spanish. So watch for that in the next week or so.
Okay, I didn't see any other questions in the chat. Does anybody else have any other questions they would like to ask now?
And with that said, Tracy, if somebody has a question, just interrupt me. But as I mentioned, we have a project webpage. On the we're going to be posting the recording and the link to the evaluation. Now, somebody wrote in the text box and they said the link to the survey was not working, which I apologize. I tested that link today and it was working. So, but if you want, you guys could take a screenshot of this, or you could take a picture off your phone of this, and hopefully it will get you to the survey. And if it doesn't, I apologize. I will look into it, and we have a list of everybody who was on the training today, and we will follow up with you in an email and send you a link that works if this is not working.
Somebody
then-
sent, somebody resent a link, because the initial one didn't link, but the last link does work.
Okay, great. So that link is going to be, so if you guys can pull it out of the chat box, you could just go in and just capture it. And then when you can, click on it and just go ahead and do the eval and get it done. We do ask that everybody has to do an eval of all 3 trainings in order to get the full credit in order to get the credit at the end of the project. and I'm your contact for the QI project. I'll be following up with all the QI leaders to go over some of the administrative stuff in terms of like how we're going to get everybody their credit. And in the meantime, this slide gives you the link to the evaluation, and then within the next couple of days, we will have the recording. We're going to edit the recording and we're going to put it on our project webpage. And then if you see that link that says the YouTube, if you go to that link, that's where the recordings of the trainings will be available. And we will be working with you guys to get the people that didn't attend live who want to participate in the project, to get them to be able to just watch the recordings. And then after they watch the recording, they can do the evaluation, and we'll get everybody up to speed that way. And again, our project web page is going to have updates. It already has a lot of the resources we just showed you in this presentation. They're already out there on the web page. So when you get a chance, you can go visit that. And then very soon, the assigned QI coach to your group will be following up with you. And what we want to do is help the programs that have not yet identified a risk assessment tool that they want to use, to help you figure that out. And then to be thinking through the logistics of how you're going to operationalize it, so that what you're doing will carry over into the work of your family medicine residency program and into the clinics. And at some point, you'll probably want to get your IT person involved to think through how are you going to be able to document what you're doing in the patient record, and like be able to easily follow it, and to be tracking the patients, and to try to put an alert within your EMR for patients who are positive for who have a positive screen for hereditary breast cancer, and especially those that have been identified as having the BRCA genes. Are there any other questions for today's presentation? No? Well, I just want to say on behalf of everybody, the PAC, I'm so excited to be working with you guys on this project. It's a wonderful project. And I know there's a lot of great things that are going to come out of the pilot. And we're going to learn so much from the pilot. And the goal is then to take what we learned from the pilot and to try to develop something that could be a broader national HBC QI project.
Yeah, and I just want to add thank you to everyone who's participating. And the CDC and the National Association of Chronic Disease Directors really is excited about seeing what family medicine can do with these materials and learning from that experience. So your work is really valuable. And as Kathy mentioned, hopefully it will end up spreading, and we'll be changing healthcare around this topic. So, Tracy, do you want to say anything to send us off? Nope, you're muted.
Oh, of course. I clicked it and didn't turn over, but again, so one, thank you to all of our participants for coming tonight and being engaged, and thank you for all your questions. Again, thank you to our speakers for tonight for your willingness to do this education, and thank you to the entire PAC for your work on this. So looking forward to working with everyone, and please reach out if you have any questions.